Chapter 4: Health Promotion and Illness Prevention. Many women initially enter the healthcare system because of some reproductive system related situations such as a pregnancy, irregular menses, a desire for contraception, or an episodic illness such as a vaginal infection. Once the woman is in the system, it is important that healthcare providers recognize the importance of health promotion and preventive health maintenance and offer these services across the lifespan of women. A woman's entry into healthcare is often associated with pregnancy for either diagnosis or actual care. Early entry into prenatal care, preferably in the first trimester, allows for identification of the woman at risk for complications and initiation of measures to prevent problems or treat them if they arise. Major goals of prenatal care are listed in box 4-2 on page 45 in your book. These major goals of prenatal care are to define health status of the mother and fetus, determine the gestational age of the fetus and monitor fetal development, identify the woman at risk for complications and minimize the risk whenever possible, and provide the appropriate education and counseling. A holistic approach to women's health care goes beyond simple reproductive needs and includes a woman's health needs throughout her lifetime. Many women first enter the healthcare delivery system for a Pap test or for contraception. Visits to the nurse may be their only contact with the system unless they become ill. Some women postpone examination until a specific need arises, such as pregnancy, infertility, pain, abnormal bleeding, or vaginal discharge. Healthcare needs will vary with culture, religion, age, and personal differences. The change in responsibilities and roles of women, their socioeconomic status, and their personal lifestyles also contribute to differences in the health and behavior of women. More than half of the pregnancy in the United States each year are unintended, and the majority of these occur in the 10% of women who do not use birth control. Education is the key to encouraging women to make family planning choices based on their preference and actual benefit to risk ratios. Providers can influence the user's motivation and ability to use the method correctly. Women also enter the healthcare system because of their desire to become pregnant. Approximately 15% of couples in the United States have some degree of infertility. Many couples have delayed starting their families until they are in their 30s or 40s, which allows more time to be exposed to situations that affect fertility negatively. In addition, sexually transmitted infections, which can predispose to decreased fertility, are becoming more common, and many women and men are in workplaces and home settings where they may be exposed to reproductive environmental hazards. Infertility can cause emotional pain for many couples, and the inability to produce an offspring sometimes results in feelings of failure and places inordinate stress on the couple's relationship. Much time, money, and emotional investment can be used for testing and treatment and efforts to build a family. Steps toward prevention of infertility should be undertaken as part of ongoing routine health care, and such information is especially appropriate in preconception counseling. Irregularities or problems with the menstrual period are among the most common concerns of women and often cause them to seek help from the healthcare system. Common menstrual disorders include amenorrhea, dysmenorrhea, premenstrual syndrome, and endometriosis. Also, menopause or perimenopause is another reason some women will enter or seek help from the healthcare provider. We know that menopause is a natural transition caused by a drop in estrogen. Typically, these women, you hear, oh, I'm going through the change. Basically, when a woman reaches menopausal age, she would no longer be able to produce eggs and have children. Vasomotor symptoms such as hot flashes, or as I like to call them, power surges. A lot of women who are menopausal complain of having hot flashes that they can't control. They happen whenever. I've had a lot of women complain, I wake up and I'm just soaked with sweat at night. All women need to have factual information, the dispelling of myths, a thorough examination, and periodic health screenings thereafter they reach menopausal age. We have talked many times about barriers to seeking health care. We know that some of the major barriers to seeking health care are financial issues. Maybe people don't have insurance coverage. If they do have insurance coverage, they still can't afford the insurance premiums. Those who don't have insurance may not seek care because they fear that they may have these large medical bills. Definitely culture issues come into play with seeking health care. Some cultures are less likely to seek health care, especially preventative health care. They like to wait until the issue has exacerbated, then they seek health care. Gender issues, we know women, of course, we go to the doctor more often than men do. So these are just some barriers to seeking health care, and we've heard these barriers several times throughout these first few chapters. Health risks in the childbearing years. Maintaining optimal health is a goal for all women. Essential components of health maintenance are the identification of unrecognized problems and potential risk, and the education and health promotion needed to reduce them. Female teenagers who enter the healthcare system usually do so for screening or problems such as episodic illness or accidents. Gynecologic problems are often associated with menses, either bleeding irregularities or dysmenorrhea, vaginitis or leukorrhea, STIs, contraception, or pregnancy. The adolescent is also at risk for the use of street drugs, eating disorders, and depression. Pregnancy in the teenager who is 16 years of age or younger often introduces additional stress into an already stressful developmental period. The emotional level of such teens is commonly characterized by impulsiveness and self-centered behavior, and they often place a primary importance on the beliefs and actions of their peers. In an attempt to establish a personal and independent identity, many teens do not realize the consequences of their behavior, their thinking process, and do not include planning for the future. Young and middle adulthood. Because women ages 20 to 40 have a need for contraception, pelvic and breast screening, and pregnancy care, they may prefer to use their gynecologic or obstetric provider as their primary care provider. And we're seeing this a lot more. A lot of women, instead of having a general practitioner, they instead will use their OBGYN as their primary care physician, and more OBGYNs are starting to treat things other than pregnancy or gynecologic related issues. They may be treating women for high blood pressure, sometimes diabetes. It kind of depends on the provider and what they're comfortable with treating. Women of later reproductive age are often experiencing change and reordering personal priorities. In general, the goals of education, career, marriage, and family have been achieved, and now the woman has increased time and opportunity for new interests and activities. Social and cultural factors. Differences exist among people from different socioeconomic levels and ethnic groups with respect to risk for illness and distribution of disease and death. Some diseases are more common among people of selected ethnicity. For example, sickle cell anemia in African Americans, Tay-Sachs disease in Ashkenazi Jews, adult lactose deficiency in Chinese, beta thalassemia in Mediterranean people, and cystic fibrosis in Northern Europeans. Cultural and religious influences also increase. Okay, let's try this again. I am not up to date on how to edit the video, so I'm going to start my last sentence over because I got a little, Cultural and religious influences also increase health risks because the woman and her family may have life and societal values and a view of health and illness that dictate practices different from those expected in the Judeo-Christian Western models. These may include food taboos or frequencies, methods of hygiene, effects of climate, care-seeking behaviors, willingness to undergo screening and diagnostic procedures, and value conflicts. Use of illicit drugs and inappropriate use of prescription drugs continue to increase and are found in all ages, races, ethnic groups, and socioeconomic levels. Addiction to substances is seen as a biophysical disease, a biopsychosocial disease, with several factors leading to risk. These include biogenetic predisposition, lack of resilience to stressful life experiences, and poor social support. Because of the risk to the unborn children and financial concerns, pregnant women who abuse substances may now face criminal charges under expanded interpretation of child abuse and drugs trafficking statutes. At least 24 states have attempted to prosecute a pregnant woman on a variety of charges for suspected harm to the fetus. Smoking in pregnancy is known to cause a decrease in placental perfusion and is one cause of low birth weight in infants. Prenatal alcohol exposure is the single greatest preventable cause of mental retardation. Alcohol use during pregnancy can cause high blood pressure, miscarriage, premature birth, stillbirth, and anemia, and what you'll learn later on this semester, fetal alcohol syndrome. I'm not going to go into much detail of illicit drug use. You can read through these in your textbook. The one thing I do want to talk about is cocaine use in pregnancy, and when we get into high risk antepartum, we'll learn about some of the things that cocaine use in pregnancy causes. The main issue we have when a pregnant mother is addicted to cocaine, she usually will have, or the cocaine use can cause what we call abruptio placenta. This is where the placenta detaches from the side wall of the uterus. This can cause neonatal death. It can also cause severe neonatal depression in utero. This mom who comes in with her placenta tearing away from her uterus, she's at risk for herself dying because of hemorrhage and also for the unborn fetus to die, because that placenta is the baby's lifeline. If my placenta is not attached to the uterus, my placenta is not being perfused. If my placenta is not being perfused, my baby is not being perfused. So this is a baby who is in severe fetal distress. We know that inadequate nutrition during pregnancy can cause babies to be born low birth weight. They could also be born prematurely. Other nutritional things that come into play, our society is getting bigger, so we're seeing a lot more of pregnant moms who are clinically obese. Other considerations, especially we see this a lot in my teenagers, They don't want to become fat while they're pregnant, so they could develop eating disorders such as anorexia nervosa or bulimia. I've had maybe one person in my 16 plus years experience who had anorexia nervosa while pregnant. She would not eat anything. We had to bring her into the hospital and put her on TPN. She had to have a sitter because she would pull out her IV access because she did not want the nutrition. And we had to have psych involved. It was a mess. I've never seen anyone so cachexic and pregnant. And this poor baby, the thing with my fetus, whatever maternal stores the mom has, that baby's gonna take it. So once those maternal stores are depleted, that's when my baby starts to get into some distress. So we had her in the hospital. We were giving her TPN through the IV, trying to get weight on her. And I don't remember the outcome. It was so many years ago. But I've actually had a pregnant person with anorexia. Typically what I see are my teens. They don't want to get fat, so they just don't eat as much. Or then you have the other extreme where they're teenagers and we're trying to push on them, eat your fruits, your vegetables, your milk, your water, a well-balanced diet, and they look at you and go, yeah, I had chips and a soda or McDonald's. So nutrition in pregnancy is a very hard concept to get people to get on that track to where they're doing things that are healthy for both themselves and their baby. Physical fitness and exercise. We do promote physical fitness and exercise during pregnancy. Pregnancy is not the time to go start doing contact sports. I don't want my mom out there being tackled by the football players. We tell the mom that good forms of exercise, walking, low impact aerobics, swimming, things like that don't put too much stress on the body. We tell them we don't want them to try and get their heart rate too high or become too overheated. Definitely we tell them if you're outdoors exercising, make sure you're drinking water before, you're drinking water during, and you're drinking water after you exercise. Because one thing, if my pregnant mom becomes dehydrated, what happens to muscles when you're dehydrated? You cramp up. What is my uterus? A big muscle. So when my pregnant moms get dehydrated, they will start to have contractions. So we have to make sure that we tell them to make sure they're drinking enough fluids when they're exercising. The modern woman faces increasing levels of stress, and as a result is prone to a variety of stress-induced complaints and illnesses. Stress often occurs because of multiple roles in which coping with job and financial responsibilities conflicts with parenting and duties at home. Because it is neither possible nor desirable to avoid all stress, women must learn how to manage it. Potential risks related to sexual activity include undesired pregnancy and STIs. The risks are particularly high for adolescents and young adults who engage in sexual intercourse at earlier and earlier ages. Most women of reproductive age are relatively healthy. Heart disease, lung, breast, colon, and other non-gynecologic cancers, chronic lung disease, and diabetes are all concerns for adult women because they are among the leading causes of death in women. Women are at risk throughout their reproductive years for pelvic inflammatory disease, endometriosis, STIs, and other vaginal infections, uterine fibroids, uterine deformities such as bicornate uterus, ovarian cysts, interstitial cystitis, and urinary incontinence related to pelvic relaxation. These gynecologic conditions may contribute negatively to pregnancy by causing infertility, miscarriage, preterm labor, and fetal and neonatal problems. Female genital mutilation is practiced in more than 45 countries, with the majority of these countries being in Africa. As immigrants from these countries arrive in North America, nurses in the United States will see patients who have had such procedures performed. Environmental hazards can affect fertility, fetal development, live birth, and the child's future mental and physical development. All women at all ages will receive substantial and immediate benefits from smoking cessation. However, this is not easy, and most people will attempt to stop several times before they accomplish their goals. Many are never able to do so. Health screenings. Periodic health screening includes history, physical examination, education, counseling, and selected diagnostic and laboratory tests. This regimen provides the basis for overall health promotion, prevention of illness, early diagnosis of problems, and referral for appropriate management. Health protection. Nurses can make a difference in stopping violence against women and preventing further injury. Educating women that abuse is a violation of their rights and facilitating their access to protective and legal services constitute first step. Encouraging healthcare institutions to implement appropriate domestic violence screening programs is also of great value. Intimate partner violence is the most common form of violence experienced by women worldwide, with a reported incidence of 1 out of every 6 women having been a victim of domestic violence. The cycle of violence. Battering is neither random nor constant. Rather, it occurs in repeated cycles. A 3-phase cyclic pattern to the battering behavior includes a period of increasing tension leading to the battery. The battery consists of slaps, punches to the face and head, kicking, stomping, punching, choking, pushing, breaking of bones, burns from iron, cigarettes, and mutilation from knives and guns. The honeymoon phase is characterized by a period of calm and remorse in which the male partner displays kind, loving behavior and pleads for forgiveness. This honeymoon phase lasts until stress or other factors cause conflict and tension to mount again towards another episode of battering. Battering during pregnancy. Estimates of prevalence of battering in pregnancy vary, ranging from 4% to 8% to as many as 20%. Most women abused before pregnancy will be abused during the pregnancy, and the incidence may escalate. Abuse also may happen for the first time during pregnancy. During pregnancy, the nurse should assess for abuse at each prenatal visit and on admission to labor. Risk to the fetus includes increased rate of miscarriage, preterm birth, and stillbirth. Routine screening for intimate partner violence is the first way to detect abuse. The nurse should build rapport by listening, showing an interest in the concerns of the woman, and creating an atmosphere of openness. Communicating support through a non-judgmental attitude and telling the woman that no one deserves to be abused are first steps towards establishing trust and rapport. Rather than overlooking abused women as chronic complainers, astute nurses need to be vigilant for subtle clues of abuse. Learning how to assess for abuse is critical. Some basic assessment guidelines are: screen for abuse during every healthcare visit. Screening for violence takes only a few minutes and can have an enormously positive effect on the outcome for the abused woman. Any woman could be a victim. No single sign marks a woman as an abuse victim, but the following clues may be helpful. If the woman has bruises, scars, weapon wounds, If there is a reported history of injury that is not consistent with the presenting problem, bruises to the upper arm, neck and face, abdomen or breast, comments about emotional or physical abuse of a friend, frequent healthcare visits for chronic stress-related disorders, the partner's behavior at the healthcare visit appears overly solicitous or overprotective. If the partner is unwilling to leave her alone with the healthcare provider, answers all of her questions, and attempts to control the situation. These are telltale signs that the woman may be in an abusive relationship. If abuse is detected, immediately isolate the woman to provide privacy and to prevent potential retaliation from the abuser. Asking about abuse in front of the perpetrator may trigger an abusive episode during the interview or at home. Ways to ensure the woman's safety would be to take the victim to an area away from the abuser to ask questions. The assessment can take place anywhere: X-ray area, ultrasound room, the elevator, the ladies' room, laboratory that is private and away from the abuser. Typically, I like to ask the partner while I'm getting ready to take the mom to the room. I usually will tell them this is a good time to go to the cafeteria, get a bite to eat, grab some coffee, because while I'm taking her to the room, I'm just gonna get her set up, get her into bed, maybe let her take a shower, and give me like 10 minutes and you can come on in. I just want to get her settled into the room. Another time I can ask about abuse is when they're getting their epidurals, because at the hospital I worked at, we didn't let the significant other be in the room for the epidural. It was a legal issue. We had a lot of men start to pass out and hurt themselves. So, that's a time where, you can ask the partner to leave maybe 15-20 minutes, and while anesthesia's in there doing the epidural, I could, question the mom about abuse. Domestic violence is considered a crime in all states, but it varies between misdemeanor and felony offenses, the majority being misdemeanors. 40 states and the District of Columbia have laws that mandate reporting by healthcare providers in situations in which a woman has an injury that may be caused by a deadly weapon. Some states also require reports when there is a reason to believe that the woman's injury may have resulted from an illegal act or act of violence. Question. The nurse suspects that a client who comes to the maternity clinic for a pregnancy test is in an abusive relationship. The nurse includes the abuse assessment screen as part of the assessment. Although the woman was very emotional and hesitant in responding to the questions, verbally she denied abuse as being a problem. While waiting for the results of the pregnancy test, the nurse decides to teach the client about partner abuse anyway. The rationale for the nurse's decision is that all women should be informed about A, the nurse's ethical responsibility to protect clients, B, the cycle of violence which continues and escalates over time once it begins, C, women's legal right not to be controlled by men, D, the masochistic nature of women who stay in abusive relationships. And the correct answer is B, the cycle of violence which continues and escalates over time once it begins. Key points for Chapter 4. Culture, religion, socioeconomic status, personal circumstances, uniqueness of individual and stage of development are factors that influence a person's recognition of need for care and response to health care. Preconception counseling allows identification and possible remediation of harmful personal and social conditions, medical and psychological conditions, environmental conditions, and barriers to care before conception. Conditions that increase a woman's health risk also increase risk for her offspring. Periodic health screening, including history, physical examination, and diagnostic and laboratory tests, provides basis for health promotion, prevention of illness, early diagnosis of problems, and referral for management. Health promotion and prevention of illness assists women by increasing motivation, providing information, and incorporating recommendations for assessing resources. Intimate partner violence against women is a major social and healthcare problem and includes physical, sexual, emotional, psychological, and economic abuse. Battering affects all races, all socioeconomic, educational, and religious groups, and many pregnant women. This concludes the audio lecture for Chapter 4. Thank you.